Hi folks, welcome back to part 2 of a show I've been waiting to do for a long time with my guest, Dr. Eric Levy, Chief of Orthopedic Surgery at Lehigh Valley Hospital. Eric, thanks for coming back for part 2.
Tom, thanks for having me back.
Oh, but time flew so fast in part 1. We
really did.
We just covered a small part of it. I mean, there's so much you could write a textbook on omegas and all the positive effects, but I'm so excited that I started this in my practice, maybe 15, 16 years ago, and I never looked back. We were made fun of by some of our colleagues, and now hopefully it's becoming more of the standard of care.
Yeah, it really is. I mean, I think that more and more people are really onto it, and I think that more doctors are seeing results, more physicians are seeing results, and patients like with lower cholesterol numbers, lower triglyceride numbers, in combination with some other nutraceuticals, you can drop somebody's cholesterol naturally without any side effects.
Yeah. And their triglycerides.
And their triglyceride levels. And remember, omega-3s, Tom, are one of the only things in nature that can actually slightly elevate our HDL levels, which are our good cholesterol, our healthy cholesterol levels. You want your HDL to be high, you want your LDL to be low, and the omega-3s actually do that, along with lowering our triglycerides.
I think you're right. And I think the perfect storm has come around where, unfortunately, a lot of our colleagues need a pharmaceutical company to produce a similar supplement. And some of the pharmaceutical companies now are producing, and we'll talk about that in a little bit, a pharmaceutical omega, and I think there's a lot of pros to that, but I think there's a lot of cons. So we'll talk about that in a bit. Let me put up a slide that talks about the benefit, the heart health's effect of omega-3. But I looked at this, and I wanted to add to heart health, orthopedic, musculoskeletal health, total body health. But what do you think of these advantages as it relates to an orthopedic patient?
Well, I think it speaks a lot. When you think about it, you're decreasing cardiovascular mortality and disease, decreasing risk of stroke, myocardial infarction. But there's a connection, Tom. The thing is, and down the line, I mean, this stuff is all amazing. Decreasing inflammation, decreasing blood pressure. But I really think, Tom, the big thing on that slide is inflammation. And that is where the heart and our musculoskeletal system are connected. So plenty of studies to look at and talk about, plenty of studies where we look at inflammatory markers. We look at CRP and SED rates. And what we find is that SED rate and CRP are elevated in patients with cardiovascular disease. But guess what? It can also be elevated in patients with both inflammatory arthritis and non-inflammatory arthritic conditions. So there is a connection between our hearts and our musculoskeletal system. A healthy heart really helps a healthy musculoskeletal system, and a healthy musculoskeletal system also really helps the heart. Think about it. If you're sedentary, what's the new smoking is what? Being sedentary, being a couch potato. That is the new smoking. And if you're sedentary, what's that doing to your heart? So I really look at the body as really a big homeostatic mechanism, right? Homeostasis, everything works in tandem with each other, and if one system is feeling it, then guess what? Every other system down the line feels it in some way, shape, or form.
I couldn't agree with you more. I mean, I think a lot of our patients worry about their cholesterol more than their inflammatory markers. And indeed, before the cholesterol ever gets into their heart vessels, there has to be some inflammation, some damage of the endothelium. And then the cholesterol is actually part of the healing process. So that's after the fire has burned the forest for a while.
But that's the 1-2 punch of omega-3s, right? Because what do omega-3s do? They lower our triglyceride level, right? They slightly can lower our LDL levels and slightly increase our HDL levels, but their anti-inflammatory properties are what protects the walls of our vessels. If the walls of our vessels, just like you said, Tom, if they don't become damaged, then the cholesterol doesn't necessarily have as much chance to stick to the wall. So you think of your arteries and cholesterol as kind of two sides of the Velcro. If you don't damage that one side and make your artery like Velcro, then nothing less sticks to it, right? And that's another thing that the omega-3s do, is they silken the platelets. So they actually act as a natural anticoagulant, yet won't really increase your bleeding time, and won't cause some of the effects that people are told that we'll get into a little later.
I love it. I love it. I remember years ago, everybody was on these potent DVT prophylactic medicines like Coumadin and warfarin and that sort of thing. And now everybody's on a baby aspirin, but I always add fish oil to them
No
too.
doubt.
I think it's like a belt and suspenders.
It absolutely is.
You know, and so we look at pain. We look at, you know, all pain. All pain at its basis comes from inflammation, from inflammatory mediators. And so, you know, we see that surgical pain because as soon as we make an incision, there's inflammation. So the less inflammatory mediators that are released, the less pain they have. This has become part of our multimodal opioid-sparing pain management program. But you have to start it way before the surgery. This isn't the day before. This has to be a lifestyle change
Absolutely.
to decrease this pain.
Yep, along with a Mediterranean type diet, along with proper sleep, and along with proper exercise. And if you really do those three things, sleep, exercise, nutrition, before your surgery, then your recovery during and after the surgery is going to be, you know, head and shoulders above the people that don't do that.
And I think we're helping our patients more than they know. So when we put them on omega-3s for surgery, we want to decrease the inflammation, lower their need for narcotics and other pain medicines, anti-inflammatories, which we talked about. But you know, we're actually helping the chronic, the long-term burn, the long inflammation that's contributing to the diseases of aging. You know, the Alzheimer's, the memory loss, the
Diabetes.
Besides the diabetes, autoimmune disease. You know, it helps everything. It even has, you know, some helpful effects in cancer patients.
Well, there's no doubt. There was a study in Sweden that looked at women with rheumatoid arthritis and how it could decrease the frequency and severity of outbreaks of episodes of rheumatoid arthritis.
Look at our typical. What's our typical orthopedic patient right now?
Typical orthopedic patient, besides the few, are slightly, they're older, more chronologically advanced, I'd like to say.
Yes.
They're unfortunately heavier.
Heavier, 2/3 to 3/4,
And
overweight or obese.
They're usually taking multiple medications, including
Statins.
a lot of them are taking statins. A lot of them are prescribed narcotics by their physicians, by their family practice physicians or other physicians that they're seeing, pain management physicians. And a lot of them are sedentary. So a lot of them are, they kind of are at a increased risk of setting up for problems like DVTs, like problems after surgery, like infections.
Yes.
And we really have to maximize these patients' health before the surgery in order to help them succeed through the surgery better.
You know, it's amazing when I talk to colleagues around the country on my multimodal pain approach. You know, everyone over the last few years has sort of gotten into the multimodal pain approach with the opioid crisis, so they all kind of know the routine of using other medications, the nonsteroidals, the Tylenol, the Neurontin, the neuroleptics, and even some steroids. But when I start bringing up supplements, I get this cross-eyed look, and I said, you know, besides Omega, I have a whole sheet of other anti-inflammatories we'll go into on another show.
Absolutely.
But it's
and they've been used for thousands of years in Mid-Eastern medicine, Far Eastern medicine, and we're so recalcitrant to do it.
They are.
And we are because that's what we're taught. Or actually, Tom, it's more what we're not taught.
So I pulled up some old magazines that right around the time when I was looking for an alternative to the Bextra and the Vioxx issues, Newsweek and Time magazines, you know, had cover articles on fat and inflammation, and I read them voraciously. I said, I don't see this in our medical journals.
No.
But you know, they explained, and you could probably do a better job than the periodicals. But how does adipose or fat contribute to inflammation in the body?
Sure. I mean, so when we gain weight, you know, when we put weight on, we think of it as, you know, I'm carrying this extra weight around me. So I tell patients that gaining weight is really two problems. It's a biomechanical problem, and it's a biochemical problem. So it's very easy to understand the biomechanical problem. So just imagine, you know, putting a backpack on and putting 50 pounds of weight in the backpack and walking around with that backpack all day. Your joints aren't going to like that at all. Your body's not going to like it. You're going to actually feel more tired. You're not going to be able to do as much as you normally could do without that extra 50 pounds that you're carrying around. And that's pretty, the biomechanical side is pretty easy to understand. But the adipose tissue around our gut, especially what I call visceral adiposity, is actually very pro-inflammatory. So remember a couple slides back when you showed that picture of the heart and inflammation and how bad chronic inflammation is for our bodies. That fat around our gut is very pro-inflammatory. And inflammation is good, Tom. Inflammation can be good, right? We talk about acute inflammation. So if one of your athletes that you treat, sprains an ankle or has an elbow injury, the inflammation is good. They need that inflammation. The mediators come in, they clean up the mess, and then those mediator cells go back in their cages. Chronic inflammation, though, is the danger. And chronic inflammation is when these cells that hang out in these cages, and normally the body releases them when needed and brings them back into the cage. Chronic inflammation is when you open that cage and the chronic inflammatory mediators have a party, and nobody's directing them back into the cells. They're direct into their cages. They're just kind of hanging out, and that's where you get that arterial damage. That's where you get the damage to our joints, and that's where that chronic inflammation plays its sinister role. And that's what that adipose tissue around our guts contributes to, that chronic inflammation.
I always tell people, they look at just the way you explained it is great. The weight can be a mechanical issue that wears out their joint. But they look at me and I say, the number of total joints I do in patients that are between 40 and 60, relatively on the young side, they're all overweight. They're all overweight. And I said, so they understand that the weight wears out their joint. I said, but just as you explained, the chemical mediators work at night. When they're sleeping and they're in bed, those chemical inflammatory mediators are wearing out their joints. Because you see women that are 45 years old, they have a BMI of 40, 100 pounds overweight, they never did a lot of sports, and their knees look like they're 85. But more so than just the weight wearing it out. Their whole joint is inflamed, all of their joints. So it's absolutely amazing.
Yeah, and the issue, Tom, is a lot of these patients come in and just think that a joint replacement is the answer.
Yeah.
Well, it's not necessarily the answer. First, you have to fix the body first, and then you can change the tire. If you don't fix the body first, then replacing that joint, what's going to be the longevity of that joint?
I agree.
It's going to eventually fail, and that's the conversation that we have to have with our patients regarding their weight, regarding their habits, such as smoking, alcohol intake, lack of exercise, lack of sleep. Those are the things that we can really improve upon before we do the joint, so their joint lasts.
And as you said, when you have too much omega-6s that are just chronically pumping out the inflammatory mediators, there's not enough omega-3 when it should be balanced. Americans want a quick pill. They want a quick
fix.
They want a quick fix. And the first step is an omega. That can help balance that omega-6 and omega-3, but unless they combine it with lifestyle changes, it's not going to make a big difference in the long run. So stay with us. We're going to come back with more helpful information. Folks, welcome back. I'm with Dr. Eric Leiby, Chief of Orthopedic Surgery at Lehigh Valley Hospital, and we're discussing the role of omega-3s in an orthopedic practice. So Eric, when we left off, we were talking about some of the periodicals. This was one of my favorite. I just looked back at this Time magazine. I'll throw it up here on the screen, where a patient said there was more information in this article than I received in the past year from my family doctor, neurologist, and orthopedic surgeon combined. This was somewhere around 2004. I hope we've come.
Pretty scary.
It is scary.
You know why it's scary? Because I don't go to Time magazine for my information.
Yes.
And for someone to say that I read an article in Time magazine or Newsweek or People or Us, whatever the magazine they're reading, and they get more information from me, that would scare me as a physician, because that would mean I'm doing something wrong.
And it was a great article, I have to say. I learned so much because that was right at the time I was investigating it. And they had it nailed. They had, inflammation as the basis of many of the acute and chronic diseases. But anyway, I thought that was interesting. But and I also want to put up this slide because you use this term omega anemia in this country as the number 8 cause of death in this country, and that seesaw is sort of a good indicator, don't you think, of the issue?
Yeah, it really is, because basically what that seesaw is telling us is that we consume many more omega-6s. And remember, omega-6s from red meats and other fatty foods that we eat. And the Western diet tends to be very heavy in omega-6s and very light in omega-3s. And what we have to really focus on with our patients is really flipping that ratio and moving that seesaw the other way, and really consuming more omega-3s and really watching the amount of omega-6s that we consume.
As an orthopedic surgeon, they expect us to talk about their joints, that they're wearing out from either their life abuses, the sports they did, the previous surgery they had. They expect their cardiologist to talk about, lifestyle changes, smoking, but most importantly, diet. But I think a lot of orthopedic surgeons are afraid to talk to their patients. I see a lot of family docs that are afraid to talk to their patients about weight. A patient will come in 300 pounds and say, I'm the healthiest fat person. I just shake my head thinking of all that silent inflammatory mediators in their body.
I couldn't agree more with you. And I really feel, and I used to be scared, but now I take the attitude, the patient's going to want to hear this. And I always spend the time, and my scribe will look at me and say, God, I can't believe you spent that much time with the patient, because this is the big problem. And if we don't address this in the room at this time, then there's a problem. A lot of surgeons will say, well, go lose weight. And when you go lose weight, come back to me and we'll do your joint replacement. Well, I always tell my patient, and I have that discussion, and I say, you probably had this happen to you before. And I said, I use a golf analogy. I'm a golfer, not a good golfer, but I golf. And I tell them, imagine me giving you a bag with 14 clubs and saying, go play. And you've never played before in your life. And go play 10 rounds and come back and tell me how you did. And the patient says, oh yeah, how do you think you would do? And the patient says, oh, I don't think I'd do well. Well, if I send you out of here and say, go lose weight and come back when you did, what's going to happen? You're not going to succeed, because this is not something that happened yesterday, last week, last month, or last year. This is a lifelong thing that's occurring. There's an emotional side to being overweight. There's a physical side. There is so much that goes into it. And at Lehigh Health Network with Coordinated Health, we have a weight loss team that we can actually send patients to. And just because we say you're going to see our bariatric medicine team, that doesn't mean you're going to be having surgery. That means that you're going to be hooked up with someone that can actually help you lose weight naturally, safely, effectively, without surgery. And I've had patients do this, and it takes months, and they come back and they've lost 50, 70, 100 pounds. And then we do their joint, and they have a successful time with their joint. And that's what we have to do, Tom. We have to think about the patient's overall health, and you need to have that discussion with your patient that's overweight. I actually think it's a disservice for us not to have that discussion. And if the patient gets mad and walks out, well, then, I tried, because it is extremely important.
I agree. I think, I get so passionate about omega-3, I almost want to call it the superhero of all nutrients. I tell patients if they're going to be on one supplement and they can only afford one, to take omega-3. And one of the things, when we make an incision and we want that wound to heal, what's our biggest worry in that first 1 to 2 weeks?
Wound dehiscence, or the wound not healing.
Absolutely. And I would say most surgeons have no idea that omega-3 combined with other nutrients, it has extensive scientific evidence, many research papers, that it helps wounds epithelialize, it helps them heal over, it lowers the infection rate. We'll talk about it in another show when they combine it with L-arginine. Why wouldn't you give them a supplement with no downside that decreases their chance of an infection, increases their chance of wound healing?
Oh, and protects the walls of your vessels, because you need the walls of those vessels. You need those vessels for healing.
Yeah.
That's where the good mediators come in and actually heal them. I actually call omega-3s, and I tell this to my patients, they're really the base of the pyramid when it comes to thinking about taking a supplement. You said a couple minutes ago, if you can do one thing, one supplement, it will be omega-3s, and that's why I just call it the base of the pyramid, because it really is.
So I found this chart by the United States Institute of Medicine. Now there's actually a recommendation from the Food and Nutrition Board of the U.S. Institute of Medicine that recommends an adequate intake of omega-3 fatty acids. I never saw this before. I was doing a little bit of research. But look at basically all adolescents and adults, Eric. It looks like that's a recommendation of 1.6 grams a day. And if you go to the generic drugstore, Walmart, supermarket, and you pick up a generic fish oil, the pills have about 120 of DHA and 180 of EPA, and that's 300. To get 1.6 grams, you're going to have to take 5 pills. And most people think they're big pills, horse pills, but you know, it's really why you need a good high quality supplement that's concentrated. And I want to put this slide up too, because a lot of people say, well, I eat fish, and the American Heart Association says eat fish once or 2 times a week. Mm-hmm. But look at the average amount of EPA and DHA in your average supermarket sockeye salmon or rainbow trout. Mm-hmm. Do the math. It's 1 gram, you know. So right now, if you look at cardiologists, cardiothoracic surgeons that we saw on the slide before, if they want to decrease cardiothoracic events after heart surgery, they said 3,000 milligrams. 3
Right.
grams is good, and more is even better. The difference people don't realize is supplements, unlike medications, frankly, to a limit, the more you take, the better the benefit.
Yeah, there is a ceiling, but that's a big key, is the more you take, the more you benefit, and you're not going to get those unwanted side effects or the collateral damage that you will get. And you're right. I mean, think about that. Just getting, look, even if you choose herring or salmon, you're going to have to eat about 10 ounces of that a day, every day, to get the amount of omega-3s that you need. And it just doesn't happen. And that's where the supplements come in.
I agree. So one of the other concerns, what's a concern that you hear from the nurses before surgery?
I get this call all the time from the patient. Well, they told me to stop all my herbal supplements and told me to stop all my supplements before the surgery. And it's common. And it's done because there are a lot of supplements out there. There are a lot of herbal supplements out there, and some can cause an increased risk in bleeding time and other side effects. But I feel that omega-3s have been lumped into this incorrectly. Because my feeling is, and I know yours is too, Tom, is I'd like my patients to be on the omega-3 before, during, and after the surgery. A lot of my patients, because they know and they're on it already, they say, when can I start my fish oil? And I'll tell them, you can do it whenever you want. Just right. Don't tell them.
I know. You can't tell. It's sad, but that's true. They still get those. They still get those cards. But the FDA, here was a good thing. I've been bashing the FDA throughout the show, but the FDA actually researched almost 3,000 articles, and they said generally up to 3,000 milligrams is safe, and it's unlikely it can cause any adverse bleeding events. And I think most surgeons don't know that, and that's a lot.
Well,
most patients aren't taking
earlier,
that.
and you even said, we were looking at some data and it said even 7,000, even 25,000. In Alzheimer's patients, certain studies showed that it did not increase the bleeding time.
Yeah, it's absolutely. So I kind of want to finish up with circling back to where we started with the government and how they protected the drug cartel and that sort of thing. And sort of now the FDA, I'm going to talk about this, I'll put up a slide here, the FDA's long battle against fish oil. And so let's look at in 1994, when, again, I was in practice, they rejected the statement that that fish supplement companies wanted to put on the chart, that omega-3 fatty acids may reduce the risk of coronary heart disease. They reject that. 2001, they said, nah, it may help coronary heart disease, but it's not conclusive. 2004, it's not conclusive. 2015, it's getting close, it's getting warmer, but there's no conclusive evidence. 2017, it's okay for heart failure patients, but wait till they have heart failure before you recommend it to the general population. So I don't think they did us some favors. Then, voila, epiphany, last December 19th, New England Journal Medicine looked at a study. Of course, it was a pharmaceutical fish oil, and it was only EPA. And get this, look at the numbers. Can you imagine a new drug coming out that decreased cardiovascular deaths by 20%, heart attacks by a third, stroke by a third, unstable angina hospitalizations? It was crazy. The problem is it costs 10 times the amount of a good third-party tested omega.
Yep.
And so now, you know, it's the new reluctant hero of the medical establishment. Both the American Heart Association, the Harvard Health Publishing, Linus Pauling Institute at Oregon State, they all said it offers benefits. You can actually treat heart disease, stroke, reduce blood pressure, cholesterol, Alzheimer's disease. Absolutely unbelievable, and it's the first supplement ever recommended by the American Heart Association. So I'm going to kind of finish in the last minute and say, what if a drug rep, your wife, got a new job and she said, Eric, oh my God, I got this great medicine. It's a new product, evidence-based. It's a natural alternative to non-steroidals. It's antithrombogenic, helps prevent clots, enhances bone health, helps prevent osteoporosis, doesn't increase bleeding, decreases heart arrhythmias, helps grandpa's Alzheimer's disease, helps with sports performance, decreases cholesterol, and it's FDA approved. What would you say?
I'd say it's a no-brainer.
It's a no-brainer. Sign me up.
Sign me
sir,
up.
I'm going to leave you with that. This was great. I think we hit on a lot of good things of fish oil and omega-3. We didn't hit them all, but I don't think there's any other physician that knows as much in orthopedics about omega-3 than you do. I appreciate us. I appreciate you being here. Our patients benefit. Folks, thanks for being here. Join us on our next show about nutraceuticals in the orthopedic practice.